So to facilitate that conversation, we have our amazing DJ3 from HealthPoint, as well as some partners from the education institutions as well.
So good afternoon, everyone. Look, you made it this far. You made it this far, almost to the end of the day. Yes, you made it. So you should be celebrating. A very happy new year. I hope everything is going well in this new year for you and yours, and I hope it only gets better. Thank you so very much for taking time to come and hang out with us here today. Our goal is really to continue to move forward in 2022, to be able to create those pipelines, create those connections, create those networks, create those fabulous connections that help us do this right here. And it's to be a network of diverse, small and large healthcare providers who come together to share and take action on improving access to a skilled healthcare workforce. And I don't know about you, but I know my organization could use that. Maybe your organization could use that. And if that is the case, you're in the right place. You'll see some more information. Since our launch in 2018, HILT organizations have made improvement to equity and diversity in the region's healthcare workforce a core guiding principle across all of our committees. And as we continue forward, those points are always there: dignity, respect, hearing other voices, creating access. Today, we're going to follow our normal approach where we're going to have some sharing. And we'll do that through our featured discussions. After we've had a period of sharing, we'll transition into breakout rooms where we'll dive deeper and have those richer, more deep, more meaningful conversations. So we're going to have some of our folks kick off today and share. And you'll see them listed. We've had one quick change that, as I understand it, Vicki may not be showing up today, but just to make sure that that's the case, we'll keep that door open.
Vicki's here. She's right
Oh,
there.
great. I didn't see you, Vicki. You're hiding. My bad. The palm tree got me. Cool. I like that. So what will be happening is we're going to ask our presenters to come up. They'll share some additional information. They'll talk. They'll share. And then we'll continue to move forward into the deeper conversations. So to help us get thinking about this, there are three questions that I want you to think about. So the first question our education partners are going to come and share with us is really around what is being taught now and what's working. What's the most challenging thing about teaching these skills and helping enhance that knowledge? And then what can healthcare organizations do to partner with education more meaningfully on this topic? So with that, I'm going to go ahead and ask that Daisy would come up and kick us off in sharing. And so Daisy, just to reorient, when you come on up, just let everybody know where you're from again, your organization, and then the floor is yours.
Okay. Thank you very much for the invitation. Very happy to be here with you and to discuss about this very important topic. My name is Daisy Garcia. I am a clinical professor at Seattle University, College of Nursing, working there for about now 11 years, but teaching community nursing and public health care. Well, we call now population care. It's about like 9 years, going to my 9th year. So that will be a little bit of my background. And as you can hear, I have an accent. So originally I'm from Bolivia. And I always, when I teach with my students, I say, you're going to be practicing with me communicating, right? So in some way, they have a little bit of advantage in that, I think. I don't know. But anyway, so the questions. When I think about cultural competency, my mind goes back to the concept of what is culture, right? And we all know that we read in the books, and that's what we teach. It's a group of values, beliefs that a group has. But what I think when I'm teaching cultural competency actually is to see, to teach a content that will make the future nurse to have a capacity to work across multiple paradigms or worldviews. And then if they know that, so they can find ways to engage with clients, patients, organizations, etc. So I really keep that in mind. And I think I'm gonna just jump to say that sometimes it's difficult when you start teaching cultural competency, because as you know now in the nursing schools, for example, we really are recommended to have professors that they have master's degree or upper. So these professionals are used to complete research, do research work, right? So to work on research, maybe not complete, but to work on research. So all of them, each of them have a specific worldview, a specific way of thinking, right? So, and also it has to see with the background that they have. It has to see with the level of assimilation that they have if they come people from other countries like me, for example, right? So it is very complex, but that's what I keep in mind when I'm teaching. And sometimes I think we don't find time as faculty to discuss about those things, right? So what it is taught for our students to be competent culturally, right? So in theory, we cover many concepts about cultural sensitivity, about cultural blindness, and you can find many models of, they show us levels of cultural being sensitive or being really aware of what is happening, etc. So I think we have many models of that type. So that's the theory. We try to compare how scientists that they write about cultural competency, transcultural skills, etc. So we discuss those in classes. Our issues is that, particularly where I work is that theory had to be applied. The nursing profession, we are more, how can I say, we emphasize in hands-on work, right? So we need to help the students to apply those concepts. So we use some strategies, and those are, for example, group discussions. So we have the group discussions using specific case studies. And even now we're going into simulations here. I think it's Dr. Miller, and we're trying to integrate some concepts there and also to put the student in a situation that will use those concepts. So we're going there. We also are using, as always, the clinical part, right? The clinical rotation that they have to do, and that it is to apply those concepts in specific sites or agencies that we work. So now that we are going more to the care of population and communities, we don't call anymore in our institution community nursing or public health nursing, right? However, in my view and talking with my colleagues, also we're in a time that we are discussing about social justice. And sometimes with that concept, we're really not putting, we're forgetting a little bit about cultural competency. It's like we're trying to put everybody in one level. And we have to remember that we are different, right? So, and how we're going to get to the goals of not having inequalities, for example, is using some strategies such as the cultural competency skills. So I just wanted to reflect on that as well, because that's what I see that is happening, and that's the vocabulary that we're using more, right? So we also use, at least I use in my graduate groups, because I have also a student from the graduate program that we have at SU, the College of Nursing. So the counseling, no, I don't want to call counseling, the consultation type meeting with somebody that it is from the community that we're working with. For example, this year, the past quarter, sorry, I took students to a community and a specific institution that they were working with Latinos. So I had the students that they didn't speak any Spanish, that they never been in contact with that specific culture. So that consultation with a person that really knows the community was very beneficial for these students, and also invite people to our classes, right? Professors professors from other schools that they really understand specific communities, or people from the community to come and visit us during classes. So that really gives the students another perspective and insights to increase their knowledge and about cultural sensitivity, for example. So we're using that. And the other thing that we're using in SUCON is partnering with community organizations. So now, for example, in our college, we have the rotation of community of population care nursing. We have a whole year rotation. Before, we used to have just 1 quarter, and that was all. But we know that working in the community, we need to go longer, stay longer to really see the outcomes. So now we are doing that and partnering with many, many organizations. So here, I think the organizations that here are represented can collaborate. It doesn't mean that a student that will go to work and practice cultural competency skills and it's taking that knowledge and theory in her or his population or the care of populations and communities class cannot apply in a hospital. In a hospital, for example, we have ambulatory care. Many hospitals, they have the programs such as the maternal support services that follow up women that they already have babies. So I think that is the way that we can partner and work together. Those are some things that I was thinking when somebody sent me, I don't remember the name, the email to participate in these dialogues, in these meetings. But we're trying to, work, trying to really work on that view that when we work with a population, we have to understand that within the population, there is diversity as well. And much, much more in the United States, because I work in other countries. And the level of assimilation when they move, for example, if they are first generation, second generation, third generation. Now, something that I just want to close this with this. In nursing, for example, there was a study that they mentioned, and I think it's a little bit famous among the faculty that teach the care of populations and communities. So they asked if the professors teach about cultural competency, and 97% of the professors, they say, yes, we teach. But then when they ask the new nurses, the graduated nurses, they just remember, like 45% remember that they had that content. So I think we still need to work and create new strategies for that. And something that I was reading, and I think that I can apply to start teaching cultural competency in the schools, and something that maybe the hospitals can do is to pair students in the classes that you are teaching cultural competence with different cultures. For example, if I have a student that it's Latino, I can pair with a student that it is Asian. And they then study in that type with 20 pairs. And it was interesting how they share their, those specific values, customs, things that they can share from their own experience to the other, and they can learn more. Now, I think we have to capitalize, right, in starting from in the area, in the institutions of formation, this specific resource, which is increase the skills of cultural competency. Only on that way, I think we can help support the goals to decrease social injustice and inequalities. Those concepts are really, it's a concern of us when we are working in the health area. So that's what I can say. I don't know if I went over my 8 minutes.
Thank you so very much. And just for all of our other presenters, we do want to be timely today. We've got an agenda we want to move through rather crisply. So thank you for sharing, Daisy. And now let's transition to Corey Garcia Hansen. Corey, the mic is yours.
Great. I did prepare some slides just so that there's some visuals with what I'm going to talking about. So I think I need to have permission to share, if that's possible.
just you should be able to click your share at the bottom. Share.
It's yes, thank you. Great. So so for us at the Area Health Education Center, cultural competence is one of our core topic areas with the Health Resources and Services Administration, but we've also been with our grants with the Department of Health and developing our training resources and events around cultural humility. So, with that, I want to, just kind of note that we've been working on this for about 4 years, and this is still in its early stages, but I also really want to honor the work that and the guidance that we've received from the Community Health Worker Coalition for Migrants and Refugees and other subject matter experts, Sharana Jamerson, Li Chi Liang, and Dr. Zan Neider. And appreciate the contribution from the Department of Health on this. But for some people, kind of wonder, okay, so where is AHEC kind of coming into this conversation about education? And kind of, we're not, formally within a health professions training program, but we provide education and training that is complementary to and helps to develop and enhance the education and training networks within communities, academic institutions, and community-based organizations. And in our state, you've got the program office at the University of Washington and our Western Washington AHEC, which is hosted at Whatcom Community College, and the Eastern Washington AHEC over at Eastern Washington University. Just conceptually as well, so you're kind of getting the context here, as we're developing these trainings and discussions around cultural humility, we're kind of working across the sectors of healthcare professional development. So in those early stages around career awareness and some of the healthcare disparities and reasons for people to get engaged with healthcare, connecting students to those careers, and then connecting professionals, communities, providing additional didactic and training to prepare them to work in underserved communities and the healthcare safety net in particular, but also if they work generally in healthcare, how they can enhance their services to underserved communities. Our system of programming kind of looks like this. So cultural humility kind of falls across our pathway programs, our higher education programming in particular. It's in our AHEC Scholars program. And then when you look at health professional training programs, we provide continuing education and sessions at conferences, and we've also provided custom trainings as well to industry partners. Now, Health Resources and Services Administration formally, directs us to provide information about culturally and linguistically appropriate services. So the kind of standard class trainings, which, speaking to kind of, what are we teaching? This is pretty much the standard across, right? But what's kind of missing in this conversation? And what's kind of when we kind of talk about culture and anti-racism and diversity, equity, and inclusion. And, for some people, they also are now including justice, social justice work. How does that fit into this context of talking about it in the terms of competency? Is this something that we are ever truly competent in? And you can't really test out of this, right? Because culture is an ever evolving thing that can be place-based, that is dynamic. It's impacted by power structures and policies. It's impacted by dominant and popular culture and subcultures. There's generational differences in how we view and experience culture and develop our own personal relationship to culture and community. So when we kind of talk about well, what are we teaching? Is it really about kind of trying to give people a sense of, well, who are the different, populations that we're serving in our region, and what are their common cultural practices, and how can you work respectively with them, and kind of what are their languages? There's a lot more going on there. And should it be more about kind of our developing those skills of communications, foundational work to, create a commitment to lifelong learning and engagement with your community members, not othering, not saying, learning about the other, in context of, often a lot of cultural competency trainings, kind of use, it's almost as if white culture, which is already kind of a made up construct, is the normal. And then we're comparing everything else to this as other, and learning different cultures and being competent in these different cultures versus viewing, our whole systems as a community. So I think, we've been really trying to challenge ourselves to look at this through more of the lens of cultural humility. So it's incorporating this lifelong commitment, this self-evaluation, this self-critique that the individual is committing to, and learning how to build into their regular practice, readdressing the powers of imbalance and that patient-physician dynamic, or patient health professional dynamic, and then developing mutually beneficial, non-paternalistic clinical advocacy partnerships with communities on behalf of individuals and defined populations. And I think that this also speaks to and respects the concept of intersectionality, that you can't really put people in boxes. Our demographics serve us to, do some general surveying and understanding of kind of where people are coming from, but there's so much more beyond those check boxes in those demographics, which in a lot of ways don't speak to truly how someone might describe themselves, or make them, and in some cases can be quite alienating, and kind of already set people off in a place where they don't feel like they've been included, or are understood even from the beginning of a patient-provider relationship. So I think we need to kind of continue to evolve how we create trainings that help our healthcare professionals really develop those communication skills, that self-critique and reflection and critical thinking, and how they are able to engage in regular dynamic conversations of culture and community, as we look at how we better serve and provide culturally concordant care. So again, just to kind of give you kind of that quick overview of cultural humility. I think the other things that I appreciate about it too is that it challenges us, as far as institutions, academically and industry, and how we are looking at these power imbalances. How are we developing respectful partnerships with our communities and our patients? How are we developing systems of accountability? When we go beyond making statements, go beyond competency training, to actually do that self-reflection and that industry or institutional reflection of development in these concepts. So what we've developed thus far is, so we've done a variety of different presentations, and through the feedback have kind of landed in this place where we are developing a learning management system that has just some real basic foundational modules to start to kind of try to create this space that does provide the opportunity to lay that foundational information and build a common language and a place for whether it's students, community members, academia, or industry, to be able to come and have a place of discussion and development of their knowledge and skills around cultural humility. So the first one starts off with racial discrimination in medicine. And this goes into the history of medical racism. And I think it's important for us to make sure that we understand the history and the traumas and the challenges that are also, coming through the doors of any of our institutions as part of someone's experience with the healthcare system, and how we are transparent about how that history has impacted the communities that we serve and how we move forward through that. And then looking at the current health disparities, and to make sure that people also are in a common place foundationally about how that history and our current policies and structures are contributing to inequitable health care in our communities. And lastly, then, with those foundational pieces, then diving into the concept of cultural humility and how we then develop that commitment to this lifelong learning, starting to evaluate your individual's explicit and implicit biases and assumptions, and start to recognize where thus power imbalances lie, thus laying the groundwork for anti-racism work. And as I conclude, we are in a place where we've developed the basics and we are looking for reviewers. So if people want to engage with this work, we're not saying that we have, so at this point, created the ultimate training, but we would love to have some feedback and start to develop these more, and look at kind of what the next steps will be to be able to create that dynamic learning environment. And so what that looks like, it's about right now that we have a lot of content and we need to trim down. So it is about 25 hours of reviewing material and providing feedback, and then participating in a focus group in March. So that's what we're asking for our people, and we are compensating them for their time. Ultimately, the next steps are the development of a 4th module, evaluation methods and discussion around options for continuing education for health professionals or educators, and how these can also be used in the classroom. And then how are we developing this kind of feedback loop through this learning management system to allow the modules to kind of be able to evolve as the discussion does. So I'll close there.
You so very, very, very much. And I'm just going to say, as a learning person, love anytime we're doing learning, maximizing our systems, using our tools. Yes. Because, at Health Point, we're learning something new in 22. So that's my challenge to all of you. So with that, we're going to ask Vicki to come on forward, Vicki, and share. So let's receive Vicki at this time.
Thank you very much, DJ3. Following Corey is always a challenge. She always has these beautiful slides, but I don't have any slides, and I need to be very efficient with my time. And I see a lot of colleagues out there, so I'm really eager to hear from you. This discussion and preparing for this really brought up a lot of things for me, and I'm really happy that happened. I think I'm the Dean of Nursing at Seattle Central College. We have a very big program. We have about 320 students right now in our associate degree program. We also have an NAC program. And this is constantly something that we're looking at and working with. I know that, it's not just one, how we view this, it isn't just one approach, right? We know, especially even from the literature, that it isn't even just about putting someone in a month-long experience in maybe a different country. That's fine, but it's more about the ability to constantly, that repetition of exposing our students to these concepts, whatever. So I just want to make a mention. Anytime I hear cultural competence, it sends chills up my spine, because competence just doesn't seem like it's a word that should be here. So I appreciated, Corey, your cultural humility. And I also have cultural awareness. So I think part of it is we kind of, I hope our students aren't confused about the words that we use, but it's about the content that we provide. But I had to mention that. So what we do is, of course, we're going to make sure that we have this into every lecture, right? We incorporate that into every lecture, every case study, that we put it into our lab scenarios. And especially what we've been doing lately, even pre-COVID, but especially now in COVID, is making sure that every high fidelity simulation or even low fidelity simulation has an ability to incorporate cultural awareness. I'm going to use awareness. I'll confuse everyone. So we really do that. It isn't just a matter of what we used to do, in my mind, of saying, now we have an African-American 53-year-old patient and he has these kind of symptoms. This is more ingrained into everything, and the family response, some of their perceptions and their ability, or how they react to what we tell them in nursing. And so that's what we're trying to do. The strength of our particular program is that we have a built-in diverse student population. We are 65% plus BIPOC students. And so just by the nature of it, we've got an ability to tie in to where these students are coming from, the experiences that they've had, and how they can help contribute to other students hearing, feeling, experiencing that cultural change, that cultural differences. And so we really work hard on that. I wanted to mention too, we use a lot, this isn't novel, but we use Ethnomed, which is a free resource from the UW, and I would encourage you all to look at that. We actually introduced that to our students in Q1, and we give them a lot of exercises where we say that the one I actually observed was where they were teaching our patients and talking with their families about death and dying. So really big time, but they were to look at the information on Ethnomed. And now the interesting piece was we have a lot of students who reflect the different categories of cultures that are a part of Ethnomed. So not only could we have all students read some few really important pieces of that, but then we also were able to have the students who come from those cultures really embellish that. So that was really positive. Okay, I got to keep moving. So we really look at the contact with students from a lot of other different areas, different cultures, as being a built-in resource that we've got to maximize every single day, every single activity, every single, piece of information that we provide. Now, I want to kind of go right in, and I know time's running short, but some of the challenges that we have, and I want to mention these. Is it visible in your own educational mission, vision, philosophy? It's got to be apparent. It's got to be present so that our students and faculty know our commitment, correct? I think that's first and foremost. Our students have to see that this is meaningful to us. And I think most of us do, but I want to try to continue to drive that home and not just be fluffy words, correct? The other thing is, how do we ensure, I'm going to the challenges, right? How do we ensure that faculty have the knowledge to be able to engage in this? Because faculty are going to say, yeah, I know how to teach this, whatever. A lot of us don't, okay? And a lot of us can sit through sessions. How can we, make sure that faculty have the tools, the resources for them to be able to draw on, and then almost getting feedback for how they're doing on this. Next thing I want to mention is, how do we evaluate outcomes? Just having had an accreditation visit, part of it is, how well are we doing with this? How can we ask our students and find out from them, how is it that you're feeling we're engaging in this kind of discussion? I've got a couple more. I think one of the things that I like to talk about, I think education does foundational kind of pieces to this, and teaching and some role modeling. And I'm in the industry partners I see as reinforcement and also role modeling. So I just see us both having a piece in all of this. A couple more. Can we participate in some trainings from industry? Is there something we can do collaboratively that our students see that the staff nurses are a part of this? How can we engage in that? Let me see what else. I missed number 5. I think that's it. We don't have an immersive experience at our college, but we're trying everything we can to try to make sure that we have our folks prepared. And it's a challenge, right? It's a real challenge. So I'll stop. Thank you. DJ3, how'd I do?
You did great. You did great. And thank you so very much. And I really appreciate that point at the end about how can we do this together? Mm-hmm. That I think is going to be the key as we move forward. We're not just me or you, it's we. And when we combine, we are so much more powerful and so much more effective. Thank you so very much for sharing that. So go ahead and let's go back to our deck. And we are going to transition. We did something a little bit differently. Normally we hear from our industry partners first, and then we hear from our academic partners. We switched it up a little bit today. We led with our academic partners. Now we're going to transition back into our industry partners. They're going to be coming forward. Thank you so very much. And so we're going to open the floor to Wendy Price, Marta Sands, and then Joanne. And I'm going to ask that you would come kind of in that order. What we want to try and do is wrap up this session by 3:50, 3:55-ish, so we can move right into those breakout groups. So with that, Wendy, welcome to the mic.
Good afternoon. Hi, everyone. Thanks, DJ3. I was chagrined to join a little bit late, but Corey joined right when you were sharing and got excited about what I was hearing. So appreciate this session. And I think that our our role is to just communicate what's happening on the ground in healthcare institutions and what's changing, what we're seeing and kind of forecasting as a result of COVID. So I'll just share a few thoughts and then I'll hand it over to Mardia and Joanne. But I work for Seattle Children's Hospital, and we, like every other, I think, healthcare organization, is just incredibly impacted and continue to be by the COVID pandemic. Also, I don't think we are alone or unique in seeing a little uptick in turnover across our staff. That includes nursing for a variety of reasons. And I think we've all talked about those, but people reassessing their career path, people assessing their place in healthcare, people maybe moving to different positions in healthcare, whether that's away from the bedside or maybe to the bedside. And then we also have, people that are interested in moving to other models, whether they move from an FTE to a traveler role. There's lots and lots of movement taking place that's impacting our teams every day. So in the very short term, we're talking about every day that's in front of us. So sometimes it can be hard to think long term when we're moving toward getting through high quality patient care on a daily basis. But a few nuggets that came from some of many of you know I'm not a clinician, but a few of my clinical partners, and asking some of these questions around, what are some of the anticipated changes related specifically to nursing that is being impacted post-COVID. And we are obviously seeing an increase, like we do every winter, in RSV, influenza, and other respiratory viruses. Our teams understand how those diseases impact children and across the age span. And then we also know that we continue to need to learn the impacts of COVID. So now we have COVID, and we're going to add that to our repertoire of expertise. And we continue to learn, because this disease is impacting children in various ways as this pandemic continues. So I think those are some of the things that we're focusing on in terms of clinical skill sets and care. And I think some of the new skill sets might be around readiness for infectious conditions, proper use of PPE in different ways, adequate care spaces, how to transport patients, how to do nursing care in PPE, how to manage non-patients, families and parents. So those are some ideas just that are always present, but we also have to kind of layer that onto the new COVID environment. So I think that's just some thoughts that came up from our perspective over here. Happy to take it in a different direction, but I think I'll wrap up there and save time for Mardia and Joanne and turn it over. Thanks, DJ3.
Thank you so very much. Go ahead, Mardia.
Good afternoon, everyone. It's interesting as we look at what the demands are with the virus and how our nursing staff and in particular, but the overall care provider staff have been dealing with the pandemic. One of the things that have surfaced, and I happen to be in the DEI space. So when we look at cultural sensitivity and cultural humility, cultural competence training, and so forth, the stress that going on 2 years now of dealing with a pandemic and working in a pandemic, you really start to see, any veneer of folks who truly have not embedded cultural humility and do not or have not engaged in true cultural competence. You really start to see that veneer strip away, and that starts to show up in interactions with patients. And so we have to be extremely diligent in reminding our staff through a variety of methods, whether it's at roundtables or in-person training or virtual training online and so forth, reminding people about who is going to show up on our door and what type of care they're going to need with regard to being culturally sensitive. And And so it's important that not only the schools teach this topic and make sure that this topic is ingrained in the nursing students that are coming out today, but the folks who are already in the profession, that we as healthcare institutions continue to provide that learning and development and continue to reinforce the fact that people are showing up in whatever state and whatever condition that they're in. And in particular, the controversy around who's vaccinated and who's not vaccinated continues to rear its head, because as we continue to endure the pandemic, there is compassion fatigue. And that brings in another dimension of diversity around people's choices around the vaccine that people have to be cognizant of. And so there's a certain amount of humility that you have to have around people's choices. And so that also is playing into whether or not there is a respect and acceptance for people's decisions. And it goes right along with, is there an acceptance and there is a respect for BIPOCs, people who are in the LGBTQIA plus community, people who are differently abled and so forth. And so it's critical that people coming out of nursing school, people coming out of medical school right now are truly being taught these skills, and that the healthcare institutions themselves have put in place mitigation strategies to address cultural humility and cultural competence and so forth. And again, whoever said the competency word, I cringe every time. I'm still trying to find a different word to use for that. But that is something that we're seeing. And in circumstances where, it's volatile, it's uncertain, there's just, no end in sight. We really are trying to reinforce to our staff that you have got to have this principle embedded in your constitution, or else it's going to display itself in a way that is not how we treat our patients. So I'll say that for the folks at Swedish.
Thank you. Thank you so much for sharing that. Joanne?
Hi, Denise is actually hopping back on, so I will let her take the floor back for KP.
That is so very kind of you.
I will yield my time.
Thank you, Joanne. Except I am not sure where we are. Where are we? Give me a little bit more.
So we are in the health, Brief Center. We are in the point where we are sharing from the provider healthcare perspective. Now, you've got those 3 questions there, and we want to challenge you to share your insight in 3 minutes or less.
Okay, on what's changed.
What's changed?
So let's start there. So what's changed is that we received, I don't know if you all remember the report. I'm sure we all did. We all were really kind of startled by the number of nurses pulling away from the profession much earlier than we all plan and use as a guiding post, like retirement. People are changing careers midway at and like completely leaving the industry and changing careers. Well, that was reported earlier last year, and we began to see that. So in these skills demands, we are having to adapt to filling these gaps, but we're also with new students, but we also will need to have our nurses be familiar and be comfortable with technology, because KP is moving toward telehealth. And so that need today is, in terms of that skill, is just, I don't have really any specific skill that would be unique to being able to do telehealth, but just know that is where the direction that they'll be leaning toward. Majority of the services that we'll be providing will be presented to encourage that. It's cheaper. Well, there's no cost if they choose that route. There's is more convenient, and it can service more people this way, because they don't have to spend any time traveling to get there, and more people to touch base or touch points with to get to directly to the provider. So that's one of the things we're leaning toward. And how do we teach more effectively into including simulations and role playing? I am not sure. I know that this is something that I was prepared to address a different set of questions. So unfortunately, I didn't get enough time to get some insight on these last two questions around the skill set and how we're teaching to it. I know that Jennifer Graves had talked about simulations and the need, that's something that we need more of and wanted to do in resource sharing, specifically as in the simulation space for role playing. But I unfortunately cannot tell you more specifically what Jennifer is looking to see. We're looking for definitely BSNs, because we're going for the Joanne, help me out. What is the name of that certificate? It's a recognition. I am losing my thought on the name of the recognition, but we
Magnet
status. Yeah.
Thank you. Magnet status. And so we, we'll be looking for BSNs, and the uniqueness of the skill sets that they teach at that level will be our desire. We're still going to be looking at pipelines for the progression of the field, where you'll be going into developing OR preparation nurses. Okay, but we were also looking at the MA to LPN to RN. So we're still holding on to preparing nurses that don't want to make that big jump from MA to BSN. But in order to get that magnet status, it is going to be a higher priority to search for the BSN nurse. And I'm seeing from Meridia that we have done it in L&D. Next up is our Cancer Institute, and then we head to the ED. So maybe Meridia might be able to speak a little bit more into that, and my peers that are on the call around this space. But I am unfortunately not prepared or know all of the different things that Jennifer's looking for to do for KP. But those are the two big things that we're working on right now: is magnet status and pipelines for nurses at other levels.
So thank you for sharing that. And I thank you also for that transparency about, hey, I just don't have my toolkit with me today. Been there, done that, got the t-shirt. But the great thing about it is this is the part where we get to go into those smaller groups and have those deeper conversations. So those of you who might have brought your tools with you today, here's a great chance for you to share with us, help make us smarter, help us collectively get smarter. So what we're going to do now is we're going to transition into breakout rooms. We're going to have 5 breakout rooms that have about 8 to 9 folks in them. And each breakout room is going to focus on just really having a deeper conversation around the 3 questions that we started out with. So from an education learning perspective, we're going to think about what's being taught out there. What are we teaching now? What's working? What are most challenging about teaching these skills and knowledge? And then what healthcare organizations can do to partner with education partners to create more meaningful experiences around that. And then we'll also be diving in and having that conversation around looking at, what's changing in the space for those of us who are in that space. What do we need today? And then how are we going to teach more effectively using simulations and role plays? So again, we'll be moving into those breakout rooms, having those deeper conversations. After a period of time, we're going to bring it back to the main room. And what we really like to do is have someone share, what was the major themes that you talked about in your rooms? Were there any unanswered questions, and what are the potential implications we might see from the information that was shared. So we're going to start in a moment. They're going to start moving you into breakout rooms. Don't panic. The system will just, you're here, and the next thing you know, you'll be in a new room with new people and all kinds of cool stuff. So welcome back, welcome back, welcome back as you're making your way back. All right, so we got just about everyone back in the room. Thank you all so very much. What we're going to do is ask each one of our groups to come up and share. I was nominated for my group, so I'm going to go ahead and kick off the sharing. And as soon as I have shared my piece, I'm going to open the door very briefly for our other team members who may want to tag in to share. And then we'll go to the next group, and you can just self-nominate and go. So I'm going to start with, in our group, great conversations. We really started to dive deeper. And I think what we heard is three things. From a major theme, it is the appreciation of this concept and the importance of cultural. And while everybody used the word competency, we really prefer that humility, but really that point about acknowledging the fact that our stories are all uniquely different. Our stories are our lived experiences and truths. And so being able to understand, and I may not, and one of my teammates shared this, I may not be able to completely understand, but in that moment, to help that other person feel respected, feel that they were heard, feel that they were valued, feel that I'm there with them in that moment, and that it's genuine, is really what is that really important thing that we're striving for. And having that built into all of our learning experiences. So it's not just, we need it at our clinicians, absolutely. But at the same time, the individuals who support our clinicians, our front desk folks, our MAs who are doing that rooming, the folks like myself who facilitate learning, having that understanding across the organization of meeting people where they are, absolutely critical and essential to us being successful. We also, as a group, came to the conclusion that we wanted this experience, this knowledge to be empowering, and not just empowering for us as providers or supporters, but also for those who might be our patients. So in that moment at the point of care, they feel safe enough to share their experiences and feel that their experiences will be valued, heard, and that we as providers, as helpers, can take the important information that we need to help come to a solution collectively together. And then lastly, from a learning perspective, we really want and believe that learning can no longer be confined to just a classroom or a simulation. Yes, we need to do those learning, but at the same time, we really need to create culture that allows learning to happen at the point of care. So even having learning folks who are into the clinic spaces or into where the care is being provided, and using and seizing those moments where there might be a learning opportunity to leverage those learning opportunities to continue to enhance that learning. So I'll open the door. Team, is there anything that you'd like to share? Wonderful. So with that, we'll go ahead and ask for our next group to come forward.
So I'll speak up for our group. We had a very robust group where we had educators, folks within the workforce development space, and then some employers in the healthcare space. And a very interesting, so similar to what you shared in your group DJ3 around the term competence and humility. And I think we're in agreement that we prefer the term humility. Competence to some degree connotes, has a connotation that it's one and done, that you learn and that you're competent, and subsequently there's nothing else to learn. Whereas humility says that it is a lifelong learning journey that you go on, and that you're continuously learning as you encounter folks who are different than you. And our educators talked about the reality that we're constantly teaching care providers, nurses around who that they're going to potentially encounter. And that continuous learning also lends itself to humility. And we also talked about how students are taught that you're going to encounter different people. And some of us as employers also talked about meeting people where they are. And that's translatable to instructors as well too, how students are taught, the instructors are taught, meet the students where they are and teach them from there. And then subsequently, we're teaching in the healthcare institutes that patients come in the way that they are within all their humanity, and so meet the patients where they are and move alongside them. And when you meet the patients where they are, they're coming, in whatever state that they are, and cultural humility allows you then to be curious, to enter the space with a certain amount of curiosity, a certain amount of questioning, not making assumptions or judgments about people. And that in itself allows for you to grow. Subsequently too, as you encounter different groups of people who you may think or believe that you know different things about, that may not necessarily be true. And so we coined the phrase, tell me more. And when you start asking that question, tell me more, it opens the door for you as a practitioner to learn more about people and get some more insight. And that informs how you're better able to provide care, and care that's most aligned and appropriate for what the patient will need. And so we talked through that. And then one of our colleagues had a tool that they use, the intercultural development inventory tool, the IDI tool. And so several people in our group is using that tool right now to do that inventory and self-assessment. And as they get the results for that, they are now better able, again, to align what they themselves know about themselves with regard to their cultural index, and can then design mitigation steps for that. So those were some of the things that we talked about in our group, and how we're going to, how some folks are moving forward in this work.
So could you repeat the name of that tool? We have a question about it.
Absolutely. It's called the Intercultural Development Inventory, and IDI for short.
Excellent. And if any one of you who is aware of the tool, if you can drop a link, there you go. You rock, Julie. Way to go. Yeah. All right. Thank you so very much. How about we have our next group step to the mic?
Hi, this is Mary Pat O'Leary with the Area Agency on Aging, and I had a great group. Was robust conversation. Folks that work in academia and education said that sometimes they're given materials that are very, for lack of a better term, lame, in the sense that they really don't cover the materials the way they need to be covered in a culturally humble way. And so they have to actually take that material and revise it and look for other materials, and that the students are really pushing back in an appropriate way, saying we want to see the humility versus the competence. It's really important to include all students, not just healthcare students, along the career pathways, because this information is important for all students, regardless of what classes they're taking. It's also, I think, important in interview processes. We mentioned that when you're doing a new employee hiring, what are the questions and how are people answering those questions? And that there are cultures within cultures, so that, again, that humility, just because you say, I know a certain culture doesn't mean you know all cultures. And it could be somebody from the former Soviet Union that immigrated many generations ago, and then somebody that just came to the country. Also, really looking at applications to life and applications to reality as we're learning about cultural humility. And I'll let my team add anything else. Thank you.
Thank you. Thank you. Okay, nothing from the team. All right, so I know we've got one more group out there. Go ahead and step to the mic.
Okay, that would be our group, which had a mixture of employer and educators. And our conversation, I was in a different breakout room and got moved into an ongoing conversation around simulators. And it was a very interesting conversation around the simulators actually offering diverse characters, which are helpful because then you can use that to train to the needs of the different patient needs. So we had it's just interesting that our conversation really talked about just the uniqueness of the different cultural backgrounds and why why the responses are the way they are, based on historical needing to understand the importance of the student understanding the background and understanding from a historical context, and and also appreciating damage that was done through the research community on the African American community specifically, but and how that continues to pull a thread in what they'll share with you and not share with you with the provider, which could be detrimental in progress toward good health. Also, we talked about just the uniqueness of how people experience pain, how people digest medicine. And so I come from a healthcare industry that focused on precision medicine, specifically for that reason, because we don't have enough people in these clinical trials to tell us how people are responding to different medicines, new medicines that are coming out, and what is safe, and even to the degree of when is it appropriate for certain cancer screenings are uniquely different depending on your culture and your race. So so industry standards don't apply to everybody, and these things need to be discussed and be aware of. When you have a patient that's outside of that norm, that you have those specific conversations. And what they need to do to prepare differently to make sure that they are getting the proper tests in a timely manner. We also talked a little bit about VR, virtual reality, and how we can bring that into the fold of simulation to learn listening and empathy skills, which are also critical for our healthcare providers. That are different. So when they're interacting with someone different from them, that they take a little bit extra time to be able to answer, tell me more about that, and take the time to learn, because there's a lot in that statement. There is a lot that you can learn by just that simple statement. So it's brilliant to say, tell me more. When they say, I identify as such. And if you're not familiar with what that means, then ask, tell me more about that and what that means, and how I might interpret that. If I say something, it may not mean that I may not personally interpret that my provider doesn't know what that means, but they're asking, what does that mean to me? Because you're trying to tell me something, and I need to know what is it, why is that important for me to know? And so telling me more about that kind of expands on what you're trying to share with your provider. So I love that. And we'll be taking that little piece back. And I'll open it up to my team because they're, I'm not sure how the conversation started towards simulation, but there was a lot of deep content happening as I dropped into this group that I'd love anyone else on the group to share.
Yeah, I think right before you were able to join into our group, there was some discussion about the challenges of how to kind of intertwine this information into these concepts into training across the board, right? When we're looking at education, it's not a special topic. It's not a day of training. It's not just a continuing education. It's culture is everything about us. It's everything about our community and the place in which we work. And so I think, changing that mindset from this being a special topic to just how is it interwoven into every aspect of how we talk about, scrubbing the charts, preparing for the day, how our systems work, how the intake process happens, how the patient experience occurs, and how we debrief and how we make improvements and ever change the way in which we develop systems. And it's not just about the patient, but it's about the student experience. It's about the experience in training. It's about the employee experience. And I also, I guess one of the other things I think, that I think you actually mentioned, Denise, was empathy. That development, or possibly someone else in our group as well, talked about this. And one of the things that our current conversation and debriefing and that string around empathy made me think of was just how students, as well as our staff and our patients, feel heard, like what DJ was saying, honoring that experience. And the last thing I want to just note is that this issue around, like, if you say something that somehow you're angry, how do we actually respect that as an emotion? We don't label it as a behavior and sideline that conversation by saying, oh, that person's just angry. How are our biases playing into kind of this societal level gaslighting that we see that goes on around this conversation, as if these histories don't exist, as if people's real feelings and experience are not relevant or do not deserve the attention and the time, and how we also develop these perceptions of kind of the model minority that's soft-spoken, frequently apologizing, and high, or has to be high achieving, and somehow show people that they can overachieve and are worth staying within your care, or worth staying as a health professional. I think we have some really large challenges and issues, and a major challenge to teaching to any of this is that everybody comes to this at such a different place and a different education in their knowledge about the history and context and this soft skill side of it.
Thank you all so very, very much. You all rock. Thank you, thank you, thank you. This is why we do this. This exchange of ideas, this sharing of knowledge, this cross-pollination is critical to our partnership and building the future workforce. So thank you for taking time out of your schedule to come and do this. I realize it's a big commitment. It's the end of the day, you got other stuff going on. So thank you so very much for doing that. Need you to understand, as it says there, we're all in this together. And that nice breath is so wonderful. So Thursdays are now HILT days. As we move forward in 2022, we're trying to make it easy, trying to put all of our regularly scheduled meetings on Thursdays. So for those of you who wear like 20 different hats like I do, hopefully you can kind of put a Thursday hat on that says HILT on it. That'll help us out. We want to encourage you, you can register for the events. That helps us make sure we're targeting the information, we're getting information out to you on a regular basis. Lastly, and this is just a personal appeal from DJ3, I want to encourage you to expand the HILT network. And what I mean by that is there are other folks who are doing great work to the left and the right of you. Sometimes you can't do it all. So by expanding the network, inviting others to come and join us and be a part of that, it makes the lift so much easier. Now you don't have to be frustrated because you couldn't be here, or you don't have to be frustrated because you wanted to be a part of that. And no, expand our team, expand our reach, expand our impact. And that's where we want to go. Again, on behalf of HILT, on behalf of our convener group, on behalf of the co-captain group, on behalf of you, our members, our partners, thank you, thank you, thank you, thank you, and have a tremendously fabulous rest of the day, everyone. Bye.